The other set of diuretics that we like to use are called loop diuretics, and these are the three that we use most commonly. Furosemide or Lasix is probably by far and away the most common that we use. These come by pill form, by IV form. Those are really the two main ways that we use these, either by pill or by IV. How do loop diuretics work, or what's the mechanism of action? Well, they act directly on the ascending limb of the loop of Henle. And so again, they work in the kidney on the the renal tubules. They inhibit chloride and sodium absorption. So it works just like, in a lot of ways, like the thiazide diuretics. Remember, if we don't absorb sodium, we don't absorb water. And if we don't absorb sodium and water, then we pass sodium and water out of our system. They also do a bit to dilate the blood vessels and reduce peripheral resistance. Sometimes we call that systemic vascular resistance. Remember, we talked about that in the last first 15 minutes of this lecture. So we get a little bit of dilation and we get a lot of water and sodium removed, and that makes blood pressure go down. So what's the drug effect? We get potent diuresis and subsequent fluid loss. When we get that, we get decreased blood pressure, decreased pulmonary vascular resistance, so decreased blood pressure in the lungs, decreased systemic vascular resistance, so decreased blood pressure in the body. We get decreased blood pressure overall. We also lose potassium and sodium. So what does that mean? So we use loop diuretics when people have edema or swelling. We use them with mainly when people have heart failure and have swelling associated with that. And we're going to talk about that more in a future lecture. We also use them sometimes to control hypertension, as we've talked about. You lose fluid and you lose sodium. So what are the adverse effects of loop diuretics? Very similar to those of thiazide diuretics. Dizziness, headache, sometimes ringing in the ear, which is tinnitus, and blurred vision. Now, what you'll notice is that the side effects from both the thiazide diuretics and the loop diuretics, have to do probably with lowered blood pressure. So if your blood pressure goes too low, you're going to feel dizzy, you're going to have a headache, you might have blurred vision and ringing in the ears. So it means that they're working, but they might be working too well, and so you get those types of symptoms. The other additional adverse effects are low potassium, high blood sugar, and we do get some low uric acid in the blood. But mainly what I'm worried about you knowing is low potassium and high blood sugar. Low potassium can be life-threatening when people are taking loop diuretics. So most of the time, this is important to know, most of the time we use a potassium supplement when people are taking loop diuretics. So what do we do then? We have a third category of diuretics that we use called potassium-sparing diuretics. And these diuretics are, the exemplar one is known as aldactone, which is the brand name, or spironolactone. And what these diuretics do is they help us lose fluid, but more importantly, they help us hold on to potassium. Because remember, hydrochlorothiazide and the loop diuretics like furosemide make us lose potassium, which can be life-threatening to us. So we give someone a potassium-sparing diuretic, they actually hold on to potassium, and that way we may not have to supplement the potassium at all. These diuretics work again in the collecting ducts and the distal convoluted tubules. They interfere with the potassium and sodium exchange. That's important to know. So they block the reabsorption of sodium and water just like thiazide and loop diuretics do, but they interfere with the sodium-potassium exchange, so you hold on to potassium instead of losing it like you do with the other diuretics. So what's the drug effect? We prevent potassium from being pumped in the tubules and secreted, so we keep potassium. We block aldosterone, and I'll talk a little bit more about that later, but we like the fact that they block aldosterone, and it also promotes excretion of sodium and water, which is what all diuretics do. So why do we use them? We use them in hypertension. We use them to reverse potassium loss caused by diuretics that cause us to lose potassium. So it used to be, not so much anymore, but in some ways today, we would give potassium-sparing diuretics in addition to a loop diuretic just for the purpose of holding on to potassium. What are the side effects or adverse effects? Well, surprise, surprise, dizziness and headache, just like a side effect you would have if your blood pressure was too low. In addition, you can get urinary frequency and weakness. And because you hold on to potassium, you may get hyperkalemia. So although we want you to, the drug may make you hold on to potassium, we may want you to do that. If you hold on to too much, you get hyperkalemia. Again, kind of a unique a side effect or adverse effect of spironolactone or the potassium-sparing diuretics is gynecomastia. So this is especially troublesome in men. They get their breast tissue enlarges and can become extremely tender. So sometimes they have to stop taking potassium-sparing diuretics. And as I mentioned before, hyperkalemia. So with any of these diuretics, whether it's hydrochlorothiazide or loop diuretics or potassium-sparing diuretics, we're going to monitor what electrolyte do you think? Potassium. We're going to monitor their potassium level to make sure it doesn't get too low if they're taking diuretics like the loop diuretics, to make sure it doesn't get too high if they're taking a potassium-sparing diuretic. What are the nursing implications? Well, we need to know a thorough patient history. We need to assess their baseline fluid volume status, their intake and output, their electrolytes, their weight and vital signs, because these are the things that will change once we give you a diuretic. What vital signs might change? Think about that. We're trying to lower your blood pressure, so your blood pressure will probably change, and we need to monitor that accordingly. What's going to change? Your fluid volume status. So if we're trying to get rid of fluid, we don't want you to get rid of too much fluid. Too much fluid, when you lose that, is called what? It's called dehydration. So the way we can carefully monitor that in the hospital is monitoring I's and O's, or input and output. And as I mentioned before, monitoring those electrolytes like potassium, sometimes sodium as well. So we want to be careful that we monitor those on patients. We want to tell the patient to take the medications in the morning if it's possible at all. It becomes a problem if the patient's taking them in the evening because they could have to wake up at night and urinate, like our young man or our older gentleman in the patient teaching video did. He woke up in the middle of the night and had to run and go to the bathroom and fell down. So we don't want to disrupt people's sleeping patterns. We ask people that they take this in the morning if at all possible. Again, like I mentioned before, tell the patients we're going to have to monitor their potassium levels. We really want potassium level to stay above 3 milliequivalents per liter if at all possible. And if it doesn't, we will give them potassium supplements and probably recheck their blood level very soon. Teach the patients to maintain proper nutritional and volume status. So if they're taking a diuretic, we don't want them to get dehydrated, but we also don't want them to drink so much fluid that it counteracts the effect of the diuretic. It may be helpful to eat potassium-rich foods. Think about what those are. Things like bananas, oranges, dates, leafy greens. Sometimes by eating enough potassium-rich foods, they can get enough potassium that they may not have to take a potassium supplement. We want the patients They're taking thiazide or loop diuretics to be told to monitor their glucose. Remember, I told you that it can send the blood glucose level high, it can send the blood glucose level low. So anytime it changes that, we want especially the diabetics to monitor their glucose level. When we talk about their blood pressure being changed, we always worry about orthostatic or postural hypotension. And that means that when the person sits up quickly, they get really dizzy because their body doesn't adjust quickly enough to their head being elevated, and so they get dizzy. So we ask patients to rise from seated position slowly or rise from bed slowly. Along the lines of the fluid intake and output, we want them to monitor their daily weight. The reason we do this is because fluid weight changes on a daily basis. Fat weight doesn't. I know you think you eat a big meal, I gained 3 pounds at Thanksgiving, but it usually doesn't work that way. It's usually fluid weight that goes up and down quickly. And we always want patients to remember to return for their follow-up visits and lab works. Monitoring and adjusting people's blood pressure medications is something that takes a lot of work in order to get the person where they need to be. Once they're stable on their medications, they may not have to come in and get lab work or follow-up visits as often, but while we're trying to add more medications or change more medications, make sure we've given them enough but not too much, then we might need to have the patients come in for frequent visits. If patients become ill with nausea and vomiting, they need to let us know because that could affect their fluid status. And then we need to know about signs of hypokalemia, if they've lost too much potassium, because as I mentioned, that can be life-threatening. This has to do with, again, weighing them they should take daily weights and let us know if their weight goes up or down. And monitor for those adverse side effects, especially with the potassium sparing diuretics. We watch for hyperkalemia or high potassium level.